I'm very happy to introduce today's speaker, Dr. Biro. Dr. Biro received her dual title PhD in Communication Sciences and Disorders and Language Science from Pennsylvania State University. And after that, she just recently completed the T32 postdoctoral fellowship with us. And today we will hear about the role of area deprivation and language decline in Alzheimer's disease. So looking forward to hearing all about it.
Thank you so much for that introduction. So I'm currently I've continued my postdoctoral research over at the Laboratory for Cognition and Neural Stimulation. And this work is sort of arising from that and from my work as a Clark Scholar at the Penn Memory Center. So today I'm going to be talking about the role of area deprivation on language decline in Alzheimer's disease. And I'll also be covering implications for treatment and treatment research and recruitment while talking about this. So first, let's talk about the problem at hand. So I want you to imagine a scenario where John, an elderly man, and his wife Mary have been happily married for over 50 years and reside in West Passyunk, that's where I live, in Philadelphia. Now, in recent years, John has been experiencing progressive difficulties with language. So simple, everyday conversations are becoming a struggle, and he's increasingly having a hard time in recalling the names of common objects around his house. Now, unfortunately, due to their limited financial resources and lack of access to comprehensive healthcare services, John and Mary are unable to seek timely medical attention for his language difficulties. They face barriers such as the cost of medical consultations, transportation challenges, and a lack of awareness about available resources in the area. As a result, John's language decline went unnoticed and unaddressed for a significant period of time. John finally went to a doctor when he started to forget about recent conversations and events. Eventually, John was diagnosed with Alzheimer's disease, with a secondary diagnosis of primary progressive aphasia. This delay in diagnosis not only had a profound impact on John's ability to communicate effectively, but also placed an additional burden on Mary as his caregiver. So in this scenario, it's important to consider the influence of socioeconomic factors, specifically area deprivation, on John's access to healthcare and a timely diagnosis. Area deprivation refers to the socioeconomic disadvantage faced by individuals residing in certain neighborhoods or communities, much like West Passyunk in Philadelphia. In John and Mary's case, their limited financial resources and lack of access to comprehensive healthcare services highlight the challenges associated with area deprivation more broadly. These barriers, such as the cost of medical consultations, transportation challenges, and limited awareness about available resources, prevented them from seeking timely medical aid for John's language difficulties. So, that's sort of what my research is focusing on. I'm hoping to bridge a gap between area deprivation and what we're seeing and Alzheimer's research. Its relevance to you is that area deprivation more generally can limit patients' access to timely medical interventions across all spectrums of disorders. The problem is that timely medical interventions impact the severity and progression of language impairments in individuals with Alzheimer's disease. As for significance, well, the research on the relationship between area deprivation and language decline in Alzheimer's disease allows us to identify disparities in access to healthcare and develop treatment strategies that ensure early detection and intervention for all individuals. By studying the relationship of area deprivation and language decline, I'm essentially aiming to shed light on the different social determinants that contribute to these disparities and highlight the need for equitable representation and targeted interventions to address the problem. So first, let's talk about language decline in Alzheimer's disease and understand really the clinical impact that we're talking about here. Now, typically when we talk about Alzheimer's disease, we talk about it on a spectrum of stages. This goes from the preclinical stage. We often think of this as the asymptomatic stage or the stage before a diagnosis. Then the mild cognitive impairment might be the first diagnosis that a patient receives. This is where they have very mild symptoms of short-term memory loss that don't necessarily hinder everyday activities. Then that goes on to mild Alzheimer's disease. In this case, symptoms are starting to interfere with everyday activities. This can include things like reading problems, poor object recognition, and a poor sense of direction. Then it becomes moderate Alzheimer's disease. Here, the symptoms are starting to interfere with many day-to-day activities, and this can include poor judgment, impulsivity, and a significantly reduced attention span. And lastly, the last stage would be severe Alzheimer's disease. Here, symptoms are interfering with most day-to-day activities and can include things like vision problems. Now, the cortex that processes language is actually one of the earliest brain regions affected by Alzheimer's disease, and speech and language abnormalities can be detected 2 years before a diagnosis of AD at the preclinical stage. So this is typically the stage that we think of as asymptomatic. Well, we're actually seeing language symptoms at this early stage. Now, for patients with mild to severe stages of Alzheimer's disease, language ability is suggested to have more clinical relevance than memory, orientation, and reasoning, as language decline has been found to decline in parallel with patients' basic daily activities, such as dressing, hygiene, continence, and eating. Now, language abilities aren't only crucial for effective communication, this is serving an important marker for disease progression. And a functional impairment in Alzheimer's disease. Language decline significantly impacts the individuals who have Alzheimer's disease and their caregivers, affecting communication and their quality of life overall. There's also exciting new advancements in speech language, like processing technology that can detect subtle changes in speech patterns and language abilities that may serve as early markers of Alzheimer's disease, particularly in this preclinical stage. And these innovative approaches are offering potential avenues for early diagnosis and intervention. So focusing on language symptoms can aid us in administering treatments that can curb cognitive decline before it begins in earnest amongst patients who later develop Alzheimer's disease. So let's talk about the influence of area deprivation on language decline in Alzheimer's disease patients. So socioeconomic status, housing quality, employment, educational attainment, all of these things influence the presence of Alzheimer's disease, its severity, and its progression. And so what you're seeing over on the left-hand side of the screen is a map of Cleveland. In A, what you're seeing is a coloration indicating how deprived certain neighborhoods are. And so we call it an ADI, or an area deprivation index decile. And so 1 is considered the least deprived areas. Those are those dark blue areas. 10 is considered the most deprived areas. Those are those dark red areas. In this one study by Basaril et al. In 2023, he essentially observed that patients living in these most deprived areas had the greatest 10-year risk for developing later dementia symptoms. He also found that these factors combined accounted for 30% of the racial and ethnic differences that we often see in dementia outcomes among Black and Hispanic patients compared to white patients. And for those of you who are unfamiliar, Black and Hispanic patients are typically observed to decline faster when suffering from Alzheimer's disease. Understanding the relationship between area deprivation and language decline is crucial for addressing disparities and developing early intervention strategies. Hence, there is a need to understand what individual factors might influence the presence and severity of language disruption among Alzheimer's disease patients. And so that's what this present study is going after: the role of area deprivation, and specifically in picture naming among Alzheimer's disease patients. My research question is as follows: What is the relationship between area deprivation and the severity and onset of language decline in patients with Alzheimer's disease? So for this study, I used data from Penn's Integrated Neurodegenerative Disease Database. So for the University of Pennsylvania essentially has this giant database where all people who collect any type of dementia research, also frontotemporal lobe degeneration, Alzheimer's disease, collect all of this data and then contribute it to this larger database. And so I obtained records from patients across all of the studies that do dementia research across the University of Pennsylvania. Now, the inclusion criteria for Alzheimer's disease patients and patients with normal cognition that I used as a control group required a consensus diagnosis based on multiple assessments and across multiple physicians. So for predictive measures, I had all of my subjects needed to have address information. This is because I used their addresses to obtain 12-digit Federal Information Processing System codes that are matched to by block area deprivation index scores. So much like those scores I talked about earlier, going from 1 being the least deprived to 10 being the most deprived. Now, ADI, as it's known as, is a measure of the neighborhood level socioeconomic disadvantage. So it provides a ranking system for state, that's 1 to 10, like we saw earlier, and national level, that's from 1 to 100, area deprivation scores for by block census groups. And these scores incorporate factors related to things like income, education, employment, and housing quality. All of these scores originated from the Neighborhood Atlas team at the University of Wisconsin's Center for Health Disparities. Now, the graph that you're seeing over on the right-hand side of the screen is showing Philadelphia. So these are all of the patients that we had within INDD that were a part of Philadelphia based on how they ranked. The yellow that you're seeing there are blocks that were considered least disadvantaged. And then as you go darker into that dark purple, these are the blocks that are the most disadvantaged. And this is specifically for state rank. And just to note, these ranks are based off of the entirety of Pennsylvania, not just Philly. But here I'm showing Philly. Okay. For an outcome measure, all subjects were required to have the 30-item Boston naming task short term. Subjects with Alzheimer's disease were additionally required to have taken the Boston naming task 2 to 3 years post their initial diagnosis, 4 to 6 years after that diagnosis, and 6 to 8 years from that symptom. It's actually their reported symptom onset date. So these are self-reported measures of when their symptoms first started occurring. For an analysis approach, we actually had a lot of variability between the number of participants we had in each group, particularly that we had a bunch of participants in the ADI state rank of 1, and then fewer participants as you got to those ADI state ranks of 10, representing the most deprived areas. So I did a weighted linear mixed effects model to kind of have some statistical control over those differences, with fixed effects on the ADI ranks, and then diagnosis for model 1, and then for years of symptom onsets on model 2, and included by subject random intercepts. For predictions, compared to patients living in areas with lower levels of deprivation, patients with Alzheimer's disease living in areas of higher deprivation they would have a lower baseline language ability. So this study by Kimbaro et al. In 1996 found that cognitively intact adults from areas of higher deprivation typically score lower than adults from areas of lower deprivation on the Boston naming task. 2, they would also have a shorter time until they experienced language decline. So a study by Williams et al. In 2022 found that older adults who lived in higher areas of deprivation showed earlier and greater decline in delayed recall tasks that involved word lists. Lastly, patients would also experience more severe language decline over time if they're a part of a higher deprivation area. So let's talk a little bit about results. So this is the influence of area deprivation and diagnosis on the Boston Naming Task scores. So in blue, you're seeing the blue bars, you're seeing patients who were considered normal cognition on the Boston Naming Task. Orange, you're seeing people with Alzheimer's disease. On the y-axis, you're seeing the Boston Naming Task total going from 0 to 30. And then on the x-axis here, you're seeing ADI state rank. And remember, ADI state rank of 1 means you are least deprived in terms of where you're living. ADI state rank of 10, most deprived. So first of all, we saw a main effect of ADI state rank. So this is essentially saying that Boston Naming Task scores decreased as ADI state rank increased, and this was regardless of whether or not they had Alzheimer's disease. Patients also with Alzheimer's disease generally had lower scores on the Boston Naming Task compared to individuals without Alzheimer's disease. So really for this set of data, oops, go back. Well, here we are. On this set of data, it's not too surprising because we're comparing to normal cognition. And this measure is essentially like proof of concept of, you have Alzheimer's disease and you have patients of normal cognition. Well, they score similarly on the Boston Naming Task across groups. So those differences are the same between the bar of normal cognition and Alzheimer's disease if you're controlling for state rank. Same with ADI national rank. So remember, this is going, so here I binned it. So 1 to 10, you're seeing patients who are in the least deprived areas. 91 to 100, these are patients who are in the most deprived areas. Same story here, Boston Naming Task scores decreased as ADI national rank increased regardless of AD status. Patients with AD generally had lower scores on the Boston Naming Task compared to individuals without AD. We did see simple effects, though, in that for at least people who were in this national rank of 31 to 40, and then in that most deprived regions of living between 91 and 100 in those ranking systems, the difference between participants' scores based on diagnosis decreased as ADI national rank increased. So these people in the most deprived areas, at least for national rank, they had a greater difference between, or rather people with Alzheimer's disease were scoring much, much lower compared to the people with normal cognition in that same ADI national rank compared to other groups. So they were just doing much worse. Now let's talk about the influence of area deprivation on disease progression. So here, what you're seeing in these graphs are the 3 time points that we looked at. So the first one being 2 to 4 years, this was our comparison group. And then from 4 to 6 years is our first comparison, and then 6 to 8 years being our last comparison, with the colors just representing the different ADI state ranks. Now, for individuals with Alzheimer's disease, what we saw was that Boston naming scores tended to decrease as the disease progressed. The effective disease progression on Boston naming scores occurred earlier and had greater severity as ADI state rank increased. And so you can kind of see that here, where over here we have some decline, sort of like what we saw when we were looking at the ADI state rank in comparison to the normal cognition, where your scores tend to decrease as your ADI state rank increases, as you live in more deprivation. Well, you can see that these bars on this graph, especially over here, are all going down at that 4 to 6 year. So these people are doing much worse compared to, this group, the ADI state rank of 1, where they are just slightly affected. Now, 6 to 8 years, all of these bars are going down pretty significantly. Where you can see that every state rank pretty much after the ADI state rank of 1 has decreased in their overall scores on the Boston Naming Task, and compared to the ADI state rank of 1, where there really wasn't much change here. Looking at ADI national rank now, kind of similar story for individuals with Alzheimer's disease. These scores decreased as the disease progressed. The effect of the disease on these scores occurred much earlier and had greater severity as ADI national rank increased. And so you could see, again, with these bars, compared to that first time point of 2 to 4 years post-symptom onset, we have all of these bars starting to decrease, where they're starting to score lower compared to that ADI state rank of 1. Same for the 6 to 8 years. Again, a lot of these bars are going much further down. So they're doing much worse, and much earlier, they're doing much worse than that ADI state rank of 1. So in summary, compared to patients living in areas with lower levels of deprivation, patients with AD living in areas of higher deprivation, 1 did have a lower baseline level of language ability. 2 demonstrated a shorter time frame until they experienced language decline. And 3, they experienced more severe language decline over time. These findings are in line with previous research, which shows that performance on the Boston naming task has been found to be predictive of future cognitive decline. So if you're scoring poorly at an earlier time point, you're seeing that decline, first of all, continues much earlier than it would for somebody else who scored higher, and then also decreases at a much greater severity over time. For future directions on this study, so higher levels of education have been found to be associated with lower Alzheimer's disease risk and fewer errors on language tests among Alzheimer's disease patients. Now, we actually did use education in one of our analyses to see if it had an effect, and we didn't see any influence of educational attainment on any interactions between ADI and Alzheimer's disease. However, one thing about education is it's kind of tricky in the sense that quality of education is, often hard to control for. So one alternative that we've been considering is using the Wechsler test of adult reading instead, to use as an alternate means of sort of binning participants by their educational attainment or educational status. Race. So when controlling for race, the interactions between ADI and AD, or Alzheimer's disease, were maintained. So in this case, we had actually very few minority participants represented among the higher ADI ranks. So earlier I showed you like all of these participant groups. One of them at the ADI state rank of 1 had like 300 participants versus the ADI state rank of 10 where we had 78. Well, among the ADI state rank of 10, more than 2/3 of those participants were minority participants, compared to the ADI state rank of 1 where we had 300 something participants. Only 20 of those participants were of a minority status. So even though we're controlling for race, races are not equally represented across each of these ADI state ranks. Age, so primary progressive aphasia, secondary to Alzheimer's disease. People who have it tend to be younger and more educated than those with Alzheimer's disease without PPA. And then lastly, sex. So female patients who have Alzheimer's disease and primary progressive aphasia have been found to have a greater baseline language impairment and a larger language decline over time than male patients and patients without PPA. Now, another thing to consider with sex is that young single mothers also tend to be very heavily represented in areas suffering from greater deprivation. So a lot of times when we look at regions that have, considered an ADI state rank of 10, those participants are most often represented as young women. Now, in our study, the number of participants who are men and women across different state ranks was roughly equal. So we don't think it had an effect on our data, but it is something that we're considering going forward. So now on to the third portion of my presentation, insights. So this is implications and thoughts on finding towards just how we conduct research generally. So first of all, the importance I just really want to emphasize the importance of further investigating and addressing the role of area deprivation in neurodegenerative research. So first of all, doing research like this really highlights healthcare disparities. So the present findings shed light on significant healthcare disparities that exist among different socioeconomic groups affected by Alzheimer's disease. Understanding these disparities is crucial for ensuring equitable access to timely and appropriate care for all individuals, irrespective of their socioeconomic status. Two, this type of research is important because it helps identify high-risk communities, especially in our area. So by investigating the relationship between area deprivation and language decline, this research has the potential to identify local high-risk communities where language impairments in Alzheimer's disease may be more prevalent. So for example, West Passyunk. This information can be valuable for healthcare providers, for policymakers, in targeting resources and interventions to these specific communities in the greater Philadelphia area. So for example, South Philly has a newspaper that gets distributed to local residents. I receive one. All of my neighbors tend to receive one in West Passyunk. And this is something that studies can be advertised in. We also have a lot of local library branches that can be additionally advertised in, and parks that flyers can be distributed in. So identifying the communities that are most high risk in Philly can help us identify where we might be able to recruit and really advocate for patients that are poorly represented in our university's data sets. For tailoring interventions, so a deeper understanding of the impact of area deprivation on language decline can inform development of targeted interventions. By recognizing the specific challenges faced by individuals from economically deprived areas, we can adapt our approaches to better support and engage these patients in their treatment and care plans. And we'll talk about this a little bit more as we go on as well. So another importance for developing these studies is advancing early detection. So I talked earlier about how language can be used as a screening tool for Alzheimer's disease in that preclinical period. Well, studies like this one are contributing to a growing body of literature that is focused on early detection and prediction of Alzheimer's disease. So by identifying a potential link between area deprivation and language decline, these findings can contribute to the development of more sensitive and specific screening tools that can aid in early diagnosis, intervention, and lead to better outcomes for all patients, regardless of where they come from in life. These types of studies also drive policy change. So research that highlights the influence of area deprivation on any neurodegenerative disease like Alzheimer's disease can have broader implication for public health policies. By recognizing the role of social determinants in health in disease progression, policymakers may be motivated to implement measures aimed at reducing disparities and improving overall health infrastructure in the greater Philadelphia area. Lastly, these types of studies also encourage collaborative efforts. So the present study was a focus that was brought together by the collaboration between researchers, healthcare providers, community organizers, and different policy workers all working together to address this very multifaceted challenge faced by the diverse populations of Philadelphia that may suffer from dementia or Alzheimer's disease. By fostering partnerships, different stakeholders can collectively work together to create more inclusive and effective solutions for these patients. So I'm going to talk a little bit about Penn's recruitment efforts. So we are very aware of the disparities that we see in terms of how we are recruiting from patients who come from least deprived areas. So for example, that 365 patients with Alzheimer's disease from the least deprived area that we see in our data bank versus, that ADI state rank of 10, where we have 86 patients represented. So we've been we're attempting to improve our clinical outreach to these underrepresented communities. And I'm sure I'm preaching to the choir in terms of Jefferson as well, because this is something that I think most area hospitals and most hospitals in the United States are also facing. So first of all, to kind of improve our clinical outreach, it helps to identify barriers. So one of those barriers might be awareness of studies. So how can we best reach underrepresented participants? Well, where are we advertising our studies? For Philadelphia, a lot of the patients that we see coming in from these more deprived areas learn about our studies from community and faith-based centers, also from smaller clinical practices. So a lot of local doctors or doctors that are that at least my neighbors in West Passyunk tend to see are doctors who are based in South Philly and are small family practices. Studies can also be advertised through local radio stations such as WHYY, through community newspapers like the one we have in South Philadelphia, distributing flyers in different pharmacies or small practices, libraries, churches, and then another sort of underutilized resource is using block captains to spread the word. So I have a block captain on my street, for example, that I'll often tell about studies, and we'll get participants referred that way. Another barrier is that there is a general distrust of research in Philadelphia, and for good reason. So the University of Pennsylvania had a history of medical research on Philadelphia's Holmesburg prison inmates. So if you're unfamiliar with it, these were medical experiments performed mostly on Black inmates in Philadelphia's Holmesburg prison through the 50s all the way to the 70s. And a lot of the families that were affected by these, these research initiatives that went on in the prison still have that distrust and are still aware of that history today. So it's ever pervasive among communities that are of greater deprivation. So building trust among underrepresented communities is something that we need to focus on. So we've broken that trust. We need to rebuild it. And a part of that is not just by taking when we go to these communities, say, hey, you participate in my research and give me data, but also giving back to the communities by providing things like free medical screening. So one of the things, for example, that we've found that has been really successful in our research is providing free hearing tests and also free speech assessments by our audiologists and our speech language pathologists. And then also doing other things like providing education just generally about healthy aging and how clinical studies work and what sort of regulations we have going on today. Another thing that we can focus on, just to add to the previous point, is that a lot of people, you can build trust with communities by having people who are a part of minority populations working with minority physicians. So there was this study by Jetty et al. In 2022, I believe, that found that patient-physician racial concordance associated actually with improved healthcare use and lower healthcare expenditures in minority populations. So it's not just going to these communities, it's also involving these communities as leaders in your research. So for hours of operation, this is really when are you scheduling outreach activities. So it's essential to acknowledge that some older patients, particularly those facing socioeconomic challenges, may encounter barriers to participating in outreach activities scheduled during the work week. Many of these individuals tend to be actively engaged in the workforce still, and unable to attend events during traditional business hours. So anything in the 9 to 5, they likely can't attend. Additionally, economic constraints may limit their ability to take time off for participation. So having studies run, particularly treatment studies run after hours and on the weekends, can assist in getting more patients from these communities involved with our research. Lastly, transportation. So poorer communities tend to have less accessible public transportation. A really good example is, again, I live in West Passyunk, which is one of the most deprived neighborhoods of Philadelphia. The closest train station I can walk to is Snyder Station, and that's still a 21-minute walk away from where I'm at. And I'm, a healthy, young person who can easily walk to that train station versus our patients who tend to have more mobility issues. So it's important to account for transportation arrangements when creating your study plan. for these populations. So there are some existing resources that Penn has successfully initiated for improving participation among underrepresented communities. One is the Alliance of Minority Physicians. So again, I talked about how, so there's another study, Ferguson et al. 2022, that found that race, ethnicity, and language all have a substantial influence on the quality of a doctor-patient relationship. Minority patients, especially those who aren't proficient in English, are less likely to engender empathetic responses from physicians, establish rapport with these physicians, and receive sufficient information and be encouraged to participate in their medical decision making. So having physicians who, one, speak the language of the patients that you are working with definitely goes a long way in recruiting patients from these populations and getting them access to these types of treatment studies. Penn also has the IDEAL research. So this is the inclusion, diversity, equity, and learner research. So this is where Penn has created scholarships, aid, and different sort of career development programs for students and postdoctoral researchers, and I think also young faculty members who are a part of minority communities to both work together and participate in like outreach events. Penn Cares is a community-based organization that provides early intervention, work opportunities, lifelong support services, addressing sort of the full continuum of care for different minority communities within the greater Philadelphia area. And mostly it focuses on connecting different residents of different blocks to care providers that are close by. And lastly, the Better Center. So this is a part of the American Heart Association, and it's funded to understand and improve diversity and representation in clinical trials, specifically focused on cardiovascular health, but we've successfully recruited a lot of patients also from those trials because, they tend to have, oftentimes they have more than one disorder. So they often share their participant pools with us. So just to recap, this study that I went over found that patients living in areas of higher deprivation experienced language decline sooner and to a greater extent than patients living in less deprived areas. The significance of this research is that by shedding light on the influence of area deprivation on language decline in Alzheimer's disease, this contributes to a growing body of evidence about the importance of considering socioeconomic factors in dementia research. As for potential impact, by uncovering the relationship between area deprivation and language decline, these findings can inform targeted treatment strategies and improve outcomes and support for all affected individuals. Also, in terms of advancing understanding, this research is, attempting to advance the understanding of a complex interplay of different socio-demographic factors and cognitive decline in an AD. It doesn't tell the whole story, but it does tell a part of that story. And most importantly, it highlights the need for a more comprehensive approach that considers diverse backgrounds and experiences in dementia research more broadly. This study also draws the attention to disparities in access to healthcare and resources faced by individuals with Alzheimer's disease from different socioeconomic backgrounds. By identifying these disparities, this research is attempting to set the stage for addressing greater healthcare inequalities, especially in terms of, recruitment practices, at least at Penn, and trying to recruit people from more, more socioeconomically diverse communities. Lastly, as a call to action, I would like you guys to just take insight from this research into account when designing future studies and interventions, which I'm sure many of you already do, and I'm sure a lot of this is just preaching to the choir here. But work overall to promote diversity and inclusion in dementia research and to ensure equitable representation in your subjects and studies that you have. So thank you very much. Thanks to the LCNS for supporting me through these efforts, and the Alzheimer's Disease Research Center, the Clark Scholars, which is where I'm from, to my advisor, Roy Hamilton, to this is an undergraduate researcher, Christine Duas, who helped me tremendously in gathering all of this data, Taylor Phillips, who spearheads a lot of our recruitment efforts, along with Morgan Adams, who more greatly spearheads the recruitment efforts of the Penn Memory Center. At this point, I'm happy to take any questions, and I'd also love to hear about what sort of initiatives are going on at Jefferson in terms of, equity and recruitment.
Thank you, Dr. Biro, for a very interesting talk on a very important topic. I wanted to mention just before we go on to questions that the CME code for today's talk is in the chat, and just to read it out loud for those who don't have access to chat, it's 72 RAGS. So 72 RAGS. Thanks. Any questions?
Tifani, I have a question. Thanks for the very interesting presentation. My question is about you've touched on this in your discussion of the representativeness of the sample, and how some of the more individuals from the more deprived neighborhoods were less represented in the sample than individuals from the more affluent neighborhoods. So this sample was drawn from a Penn registry of individuals from the Memory Center who had received some of these outcome measures. Is this a sample that received care at Penn, or is this a sample that was recruited for other research studies? Is one of my questions. And then this other question is related to this idea of, are we identifying individuals as early in the stage of preclinical AD for folks who are more deprived because of representativeness of our samples, or because of access to care? Just sort of thinking about how much of the findings are due to different progression of decline in these groups, and how much of these findings might be due to when we're actually identifying individuals to give them an Alzheimer's diagnosis.
Yeah, so these are patients who were, I'll pull it back over here. So these are patients who are within the integrated neurodegenerative disease database that we have at Penn. So they're not only patients that were included within studies at the Penn Memory Center, it's also across any assessment that we've had for patients who've had any access to care at Penn, including those who may have participated in research studies at different time points. Now, for the patients who were ultimately included in the study, we wanted our patients who had Alzheimer's disease. So this is kind of the tricky part with this research, and you make a good point of how do we know, when somebody went to, first get care at Penn? Because somebody who's a part of an ADI state rank of 1 might have seen the language issues and gone and got care right away, versus somebody who maybe saw language issues but sort of delayed getting care on. Now, these years from symptom onset, these are the patient-reported years where they first started experiencing symptoms. So they come in and they say, I first noticed that I was having trouble with naming like X amount of years ago. Now, this is a very subjective measure. And unfortunately, it's the best measure we have for years of symptom onset. So it's not when they received the diagnosis, it's between when they first reported those symptoms to when they took that Boston naming test the first time. And for a lot of these patients, many of them, because we were kind of pretty strict on who we included versus who we didn't. So a lot of them had multiple Boston naming task, measures, even within like the same time point. So like for 2 to 4 years, maybe they had like 3 scores on the Boston naming task measure. And in those cases, we would always take the first one that they received.
Okay, so the Boston naming scores is not decline from a previous test, it's taking their years from onset and looking at how they performed in the Boston naming test, sort of cross-sectionally.
Yes, exactly.
Thank you.
Tiffany, this is John. Also a related question, and I appreciated your talk. It seems like you alluded to evidence of area deprivation acting kind of in two potentially different ways. One is really on access to the system, timeliness of diagnosis and stuff like that. But the other is potentially acting over longer periods of time on things that we might talk about as cognitive reserve, or stuff like that that might actually have implications for the disease progression intrinsically. And so I guess I was just wondering, severity at onset is tricky for the reasons you said. It depends on whether people are really getting identified at a comparable moment, but the rate of decline is potentially more interpretable. But that prompts the question of, do we expect decline in the ways it's being measured to be linear throughout the range in general? Or when we say somebody's declining faster than somebody else, could it be that they're in a faster changing part of the range rather than have a faster progressing disease? Does that make sense?
Right.
I think I am interpreting the question correct. In the sense of, let's say we have two people, one person's from an ADI state rank of 1, another person's from an ADI state rank of 10. Are you saying that, how do we know that their rate of decline is comparable? Is that it? Or?
Well, what I'm really asking is if you take a person who's late in Alzheimer's disease and a person who's early in Alzheimer's disease, do you expect the rate of decline as it's being measured to be the same?
No.
Right? I mean, in other words, it's a linear rate from early diagnosis to very severe, because if it's not linear in the population, then it becomes much harder to interpret differences in rates between two people unless they're starting at exactly the same rate, same point.
Right. And, that's, again, the tricky part of like going from subjective reports of when your symptoms started. So, a lot of these patients for years from symptom onset. So we filtered these patients on the 2 to 4 year mark. For the majority of them, they had been diagnosed either this was pre their Alzheimer's disease diagnosis. So when they were either at that preclinical stage or were diagnosed with mild cognitive impairment. But it isn't based on when they were diagnosed with Alzheimer's disease or not. It's just based on when they were, reported their symptom onsets to when they took that test.
No, I get that, but I won't beat this horse to death. But I guess what I'm asking is, if we simply studied longitudinal scores of a cohort over time from early Alzheimer's to late, using, I guess, Boston naming or whatever they're using to talk about rate, would we get a linear trend, or would we get a curvilinear trend, such that like late in disease you progress fast and early in disease you progress slow, or something like that? Or we don't know.
We don't know. And I think a part of it, I think, is and you're right, there's a lot of individual variability in terms of rate of decline across these populations. For literature wise, I would say that just in general, older adults who are a part of these higher, like more deprived areas, tend to cognitively decline faster anyway, and tend to do worse on the Boston naming task over time anyway, regardless of whether they have Alzheimer's disease or not. So I think we didn't look at this, but like even if we took a cross-section of like people who didn't have Alzheimer's disease just to measure cognitive decline for these ADI state ranks, we'd likely see at similar time points, similar rates of decline among them, just maybe at a higher level, like we see here, where they're scoring much higher than the people with Alzheimer's disease.
I have a question. Just this is all high follow-up comment. I mean, you're talking about sort of an intercept versus slope issue, right, John?
Indeed, and whether they're they have to be uncorrelated to make these separate.
Right, intercept versus slope. So that's something to think about. But I was going to just raise something that's come up when others, like in the TBI literature, have talked about a similarly challenging, complicated issue. I think that area deprivation is well recognized to be a summary of a complex multifactorial problem. And you alluded to this, Tifani. And I think, you know, what's challenging, and I think it's inspiring the work you're doing, but I do think that we need to unpack what are the underlying proximal causes that are impacting this cognitive performance and language deficits. So, for example, in area deprivation, we could have things like people who live in poor areas have poor access to healthy food, right, and their whole lives, right? Their area of stress, chronic stress, you know, is higher their whole lives, you know. So, and we know independently in other literatures that diet has a huge role on brain health. We know stress we're understanding more and more how much of an impact on brain health. So I just, in terms of thinking about intervening, whether we're going to intervene at the level of diet, are we going to intervene at the level of stress reduction? Are we going to intervene at the level of reducing, you know, toxins in the neighborhood, you know, environmental toxins? So we need, I mean, you need to understand the problem better, I think, in order to intervene. Would you agree with that?
I 100% agree, and I kind of touched upon this, and a lot of Alzheimer's disease literature reports that women score worse on language measures compared to men with Alzheimer's disease at like similar diagnostic time points. Well, part of this is that when we look at an ADI state rank of 10, a lot of these are young single mothers who, you know, live in these most deprived areas. Well, over a lifetime, these women are going to be experiencing a lot more stressors than, you know, male counterparts who might not be, you know, single parents, a part of the same community. So it's definitely when we have to be careful when we're reporting on things like race or sex or even like educational status and ADI rank as well in how we're finding, you know, these findings, because it is a complex problem. So, for example, West Passyunk, one of our closest high schools is the Point Breeze, and it's one of the worst ranked high schools in all of Pennsylvania. So people who have grown up in Philadelphia, lived their lives in Philadelphia, and gone through this school system aren't, you know, they don't have access to the same educational resources as maybe transplants or other communities that are part of these least disadvantaged areas. So it's definitely a complex problem and not something that this study, or really one study, that can fully address. But I think that also emphasizes the importance of getting policymakers involved to help raise up these communities, because, you know, as researchers, as physicians, we can only do so much in our outreach and engagement to communities. I mean, our lab, for example, we meet these patients when they're already diagnosed with Alzheimer's disease most often. And that's where we're starting intervention, when really intervention ought to be occurring much, much sooner.
Yeah. Thank you.
I have a comment.
Dr.
I don't know if my name, oh, I'm sorry. I can't, I'm on my phone, so I apologize. It doesn't look like my name is on the screen. Is it?
It says Karen.
Okay. So I know I'm Karen Cohen from the Aphasia Center. And so our groups are still virtual at this point at our members' request. But for those who don't know, we have one of our conversation cafes is strictly for people with primary progressive aphasia. It meets weekly, just like the other ones do on Monday. The only caveat is you have to know you have that diagnosis. We've had people in the Aphasia Center before with PPA. Some people knew, some people didn't. And of course, you know, we weren't going to tell them if they didn't know. It's been really, really interesting. And in addition to that, my mom, who was a patient of Dr. Karlawicz's at the Penn Memory Center, Passed away next month will be 2 years that she passed away from Alzheimer's. And she also ended up with aphasia too, but those were not her first symptoms. But it's been a really interesting kind of experience having this conversation cafe versus the ones where, or other ones where most people, of course, have had strokes. And then watching my mom's journey too, from a close-up perspective. It's just interesting. So your work is great, and thanks for the talk.
One of the things too, with at least not this study, obviously, but some of the other studies that we're doing at the Penn Memory Center are very much focused on identifying really features of a person's speech very early on in that preclinical stage, where they're not necessarily making very obvious errors. So a lot of times these very early symptoms look like just slips of the tongue. Like instead of saying, oh, could you pass me like the salt, they may say like, oh, can you pass me the halt, where it's just one letter and like, oh no, salt. Because a lot of times they'll correct themselves as well when making these mistakes. But you'll see early on that these mistakes, these slips of the tongue, if you will, occur at a more frequent rate among people in that preclinical stage. So it's very interesting to kind of have those discussions and think about like ways we might identify populations that are more at risk or might have these types of speech tags that we can identify later on.
Dr. Venkatesan, you have a question?
Yeah, thank you, Tifani, for the talk. I had a question about, and I apologize if I missed it, how specific this is to language, because a lot of this socioeconomic work has been done with memory and Alzheimer's disease. And if I understand correctly, you did not select specifically for PPA, just Alzheimer's disease. And there's a specific form of PPA associated with Alzheimer's, right? The logopenic form. So, I guess my question is just how specific. I mean, if you looked at delayed recall, would you find more of an effect, or what would you expect there? Like, why language?
So language for us was a focus, mainly because we are also doing a lot of these like preclinical assessments on speech to see likelihood for an Alzheimer's diagnosis later on among patients who have been, in our case, diagnosed with mild cognitive impairment. But for the Boston naming task, so a lot of these language assessments, like we see decline in other cognitive domains, so attention, reasoning. But for language specifically, what we're seeing is that a lot of the severity occurs much sooner than the severity of like certain other domains, or they decline in parallel. So you'll see that language is declining along with, say, attention and reasoning as the example. As a separate domain, it was interesting for us to look at, mainly because we see the onset of this decline happening a little bit sooner than we see some of the other domains that we looked at. I didn't report them here, but we also had the MoCA, for example, scores, and those we saw were declining a little bit later than our language scores for like the Boston naming task. So in certain respects, language, at least from what we've seen, and again, there's a lot of measures. So we have like the MINT, for example, that we could look at that we haven't assessed necessarily. And I hesitate to say that they decline differently than other cognitive domains because the research is still ongoing. But it does seem to be the case that language might decline just a little bit sooner than other cognitive features.
Yeah, and I know that we're out of time, but also just thinking about how the assessments themselves might be influenced by area deprivation and educational attainment and other factors is in other dimensions to think about, right? Because if there's baseline differences that are expected because of naming tasks that require having learned those words and all of that, there could be other factors that influence how the groups are different.
And this is one of the interests that we have in like using the reading scores as sort of a proxy for educational attainment, because a lot of these tests, aren't necessarily culturally sensitive. So, people of different cultural backgrounds might encounter words at different frequencies, which wouldn't necessarily be representative of their cognitive decline if it's like a word that's often infrequent for them versus somebody else who's in a higher socioeconomic status.
Thank you so very much.
Thank you.